You are now listening to Nailed It, the Orthopedic Surgery Podcast.
Dr. Gibbons, welcome to the Nailed It Ortho Podcast. So happy to have you on, and so welcome to the podcast.
Thank you, Dr. Cole. It's a pleasure to be on with you. The pride of Tulane, the pride of Marietta, Georgia.
I'm from Marietta, and you were once here as well at Tulane. I remember I at least scrubbed one case with you.
That's right. You were pretty young, so you probably didn't get to do much with me, but I enjoyed my time at Tulane.
Oh, that's awesome. And typically at the beginning of our podcast, what we do is we ask our guests just a couple of questions, is getting to know you a little bit better. And so I guess one of the main things is what kind of brought you into the field of pediatrics out of all the different specialties you could have gone into?
That's a good question, because that's probably, one of the tougher decisions that orthopedic residents have to make. The first thing is I didn't mind talking with parents and kind of giving them a more simple explanation of what's going on. I didn't need to use like fancy words or something. I liked, making sure they understood what was going on with their kid. But from like a clinical and operative side, I really like the idea that it's, a varied age range, from 0 to 18, and treatment is different depending on how old they are. And I like the idea of having longitudinal follow-up. So I might, treat a 2-year-old with a toddler's fracture in their tibia. And then when they're 10, treat them for their distal radius. And then when they're 14, treat them for their tibial tubercle fracture. And so I like the idea of seeing these patients over time. And kids are resilient. They're super fun. They don't ask for medicine. They want to get back to what they want to do. And so that's kind of what drew me to pediatrics.
Yeah, that is very true. The kids, they just want to go out and run and go back and play with their friends. I had a great time on P's. I had fun, talking with the kids. Secondly, I guess what brought you towards the field of just like education? We have a lot of people that are trying to figure out if they want to go into private practice, if they want to go to a hospital-based system, if they want to go more the academic route. So what brought you more towards what pushed you towards academics?
So I would say there are two things for me. So first of all, when you're trying to decide, the nice thing about academics is the infrastructure is already set up. You have partners that you can bounce stuff off of. The overhead is taken care of. So when you look at it from how am I gonna make a salary and how is my practice going to run, one of the benefits of academic medicine is that is all kind of set up for you and you don't have to worry about that. From the teaching aspect of it, when I was a resident, I could remember certain faculty that the way that they taught and the way that they showed how they did a procedure made it really clear to me, different than reading like a book or reading Hoppenfeld's or something. And so I always kind of wanted to be that person who could teach residents, and when I would show them like tips and tricks, it would make the idea of doing a type 3 supracondylar not so daunting to them. And so I really enjoy that.
Yeah, that's awesome. I think it's definitely, good to have somebody that can actually show you things. And there are definitely a lot of things that you pick up talking with somebody and learning from somebody that you don't necessarily pick up in a book, which is pretty much what you just said. But yeah, I totally agree. And the last question that I have for you is, kind of if you were just to kind of look back and you wanted to give yourself some advice in residency, you say you're a first year resident and you've gone through your residency and fellowship and now you've been in practice for X amount of years, any advice that you would give yourself?
Man, these are good questions. I feel like I'm in therapy. This is nice. I would say, looking back, if I would have prepared a little bit better earlier on for cases, read about what the pathology was and read up on the approach and then watched a video of the approach and kind of did the legwork beforehand, I think it would have been a little easier in the OR to understand more quickly what was going on and then be more confident with when it was my turn doing it myself. And if I could go back, I'd probably do that a little bit more. When you're a resident and you finally get home and after doing all that you had to do the day before, sometimes you're not really thinking like, oh, I should study for tomorrow's cases. You're kind of like, I'm going to lay down. And next thing you know, it's 4 a.m. and you're getting up again. So that's probably the thing I would do.
Yeah. No, I can completely agree with that. For example, we rotate twice on our sports rotation, which is what I'm on now. And I remember the first time I didn't really have much idea what was going on. Like, you're kind of, that some of the steps here and there, but you don't necessarily realize some of the minute things until you go and you go and you watch a couple of videos and read, different articles on the different techniques. You're like, oh, okay, that's why we're doing that way. Oh, yeah, that makes sense. Oh, okay. So yeah, I totally agree. And it is hard as a resident, because you have a lot of things going on. You're on call, and this chief is texting you and this other person's texting you. So it can be a little difficult.
Yeah, I will actually, when residents reach out, the night before or even the morning of and ask specific questions about how are we going to do this one, I always appreciate that because it means they're kind of thinking ahead. And then, when I talk about, okay, this is what we're going to do because of this, I feel like they understand a little bit better when the case actually starts.
Yeah, totally agree. So residents that are listening to this, please go and prepare for your case for tomorrow. After you listen to this or while you're listening to this, just however you do it, just go ahead and prepare for your cases tomorrow. That way you'll get the most out of it, whatever case it may be. So moving forward and kind of transitioning to our talk for today, we're going to talk a little bit about pediatric upper extremity trauma. We'll talk about a couple of different things. And I think we were talking a little bit beforehand that this will be a little bit different type of an episode, as we'll try to touch base on, the high points on a lot of these different types of injuries on upper extremity. We're not going to do supracondylar humerus because we have a whole podcast dedicated just to that, because that's very in detail, and they ask us a lot of questions about that, and that kind of deserves its own podcast, and some of these topics too as well. But we can kind of get started and say we want to start off with the top of the shoulder and go down. And so how often are you seeing medial clavicle fractures in the pediatric population, and are they really medial clavicle fractures? Can you kind of talk about like kind of what's really going on when we're suspecting that?
Yeah, I would say number one, not very common. The vast majority of the clavicle injuries are mid shaft, and when it comes to medial clavicle, the ligamentous complex at the medial clavicle is so strong that typically it's not a fracture per se, but rather like a physeal separation. And the good news is that the medial clavicle doesn't close until so late that it has tremendous remodeling potential. So the vast majority of these are treated non-operatively. What I will say is that if you do see one, I always tell the parents they're going to have a bump there because they're going to make a bunch of callus and then it's going to remodel. So if you let them know ahead of time there's going to be a bump, then as it goes down, they're not so worried, because once that callus pops up, they're always worried about, oh, what is this? Is this wrong? Just like the slide says, sometimes it can be a little hard to see. So the serendipity view can be advantageous. You're essentially looking, are the clavicles aligned? And when you see one looks higher than the other, that's typically what tips you off to something at the sternoclavicular joint. If there's any question about it, the CT, the axial views of the CT is what's going to show it. But it kind of like a SC dislocation, you can try a closed reduction, but in the vast majority of these, you don't even have to, as they have a good remodeling potential.
Right. And is it pretty similar for adults where an anterior dislocation is a little bit more is more common than a posterior? Is it similar in the pediatric population?
It is. Personally, I've seen 2 posterior dislocations. One was in fellowship and one was in 8 years of practice. And so they're extremely uncommon.
Yeah.
Those are the ones that you don't want to mess with until you have all your ducks in a row with your imaging and assuming they're not having any symptoms from it, you can also treat those non-operatively because they tend to do well.
Yeah. And are those one where if you have to take those to the OR, not typically, but in some of the books, they'll say you should have a cardiothoracic surgeon on standby. Like, just like you were saying, have all your ducks in a row, be as prepared as you can for these.
Yeah,
And
and it, if you're ever given a question about this, they're almost always the posterior dislocation, because they want you to know how to be safe and know not to, try and tug on it in the ER and cause a potential devastating vascular injury.
yeah. Yeah. All right. Yeah, that sounds good. So, and the non-operative treatment is just typically a sling for X amount of time, and then you start them off with physical therapy after X amount of time, or in the pediatric population, are they pretty okay without therapy?
I would say it's probably half and half in my anecdotal experience. The younger they are, the less therapy they need.
Right.
Typically younger people will kind of self-limit. And so after 2 weeks in a sling, they'll start to move it on their own. They don't get stiff from this. So if you want to keep a sling on for an extra week or two, that's totally fine. And, typically they may cosmetically have a little bump there compared to the other side, but in the majority of cases, I've seen it go away.
Yeah. And speaking about, I guess, little bumps on the shoulder, if you go to kind of these clavicle fractures now, is there any difference in treatment? Let's talk about mid-shaft clavicle fractures. How often do you see these? And then I guess what's the treatment algorithm difference between adults and necessarily pediatrics? Because, some may be a little bit different how you treat it.
Yeah. So, I'll separate it into two categories. So pediatric or adolescent. So in the pediatric clavicle, there's almost no reason to fix it. The healing rate, the return to level of function, the complication rate all favors non-operative treatment when you're pediatric, like younger than 10. Obviously there's going to be some outliers here or there if it's tenting the skin or if it's open or something like that. But the great majority of midshaft clavicle fractures in pediatric population can be treated non-operatively. They will continue to remodel for a long time. So even in an x-ray like this one that you have, you can see callus. Clinically, it won't look too different than the other side. Once you have a bunch of bridging callus, they usually have no difference in shoulder range of motion on the affected side compared to the other side. So those, there's usually not a reason to fix it unless otherwise stated, with being open or tinting the skin. Occasionally you can fix it if they're if it's like an MVC and they have a broken clavicle and a humerus fracture and a distal radius all on the same side, just to get them up and moving quicker. But your average midshaft clavicle is from a fall, from sports, sometimes from a car accident, and they can be treated non-operatively, and they do really, really well. Now, the second part of that is the adolescent population. Generally, it's the same mantra where they heal reliably and they do well. And even when you see that classic Z deformity, as it heals, it keeps looking better over time. The main controversy becomes, okay, what if you're an athlete? What if you're a high level athlete and it's your dominant arm? What should you do then? There is good literature that shows that fixing it gets you back to sport definitively quicker than non-operative treatment, but you still have a relatively high complication rate, anywhere between 15 and 30%, whether it be skin irritation from prominent implant or infection or a numb spot or something like that. So that's kind of a discussion between you and the patient if it's their dominant arm and they're a high level athlete, giving them the pros and cons. So if they're out of season, leads a little bit more towards treating it non-operatively. But if they're in season, especially if they're a senior in high school, then you got to have that discussion of, okay, should we fix this to get you back out there?
Right. And for in your typical algorithm for your non-operative treatment is sling for what, about 2 to 3 weeks or so, and then you get them started with therapy in around 4 weeks once you see a little bit of callus, as you were talking about.
Yeah. So if you're an athlete, sling for 2 weeks, usually you start to develop callus. Once there's callus, the bone isn't going to move anymore, so they can move their arm. They can start getting it strong again. Physical therapy will help it get quicker. Then it's anywhere between 6 and 12 weeks after the injury before you can get back to sport, depending on what the sport is. Obviously, football takes the longest to get back because the last thing you want is them going back too early, refracturing it, and then starting the process all over again. The younger kids typically don't need physical therapy. They'll get their strength back just starting to use their arm again.
Okay. Yeah. All right. That makes sense. So even if we see these displaced fractures in the pediatric population, they can still be treated non-operatively, and they do just fine, with non-operative treatment.
They really do. Now, some people might have differing opinions, but in terms of function and healing reliability, non-operative treatment of clavicles is generally first line for almost all pediatric and adolescent clavicles.
Okay. And so say, we're continuing to move down the arm or down the extremity, or maybe to the side, if you want to be more technical, lateral. But say what makes the, we're going to proximal humerus now. So what makes the proximal humerus, I guess, from a physiology standpoint or growth standpoint, a little bit different, and how you can approach it and treat it? And then what is kind of your treatment algorithm, when you see these?
So the proximal humerus is the magic bone of the body. When you're talking about areas that grow more, have more remodeling potential. So your proximal humerus, 80% of your humerus, your distal radius, 80% of your radius. And so fractures around there can remodel better, and so they can tolerate more deformity at first. Especially the proximal humerus. If you go on Ortho bullets and look at, the angulation and the amount of displacement that you can tolerate, it's pretty funny. It actually says younger than 10 years old, any amount of angulation, any amount of translation. And in my anecdotal experience, that is literally true. It has so much remodeling potential. So typically, these, if they're going to be treated operatively, they tend to be older patients nearing skeletal maturity, and they tend to be fixed percutaneously, like you can see on these x-rays here, because you can get it in an acceptable place without needing a big plate and screws. In terms of pearls for the proximal humerus, essentially for it to sit in a better position and start to remodel, you want the deltoid to relax, because when you have a fracture there and it bleeds, everything's irritated, the deltoid is contracting and it's pulling that proximal humerus up. And that's why that shaft slides laterally and proximally, creating that varus deformity that you routinely see with these. So the way to relax the deltoid is one of two things. Either if you're going to treat it in a sling, it's helpful to have the sling be almost loose and not tight. If the sling is tight, then it's pushing up their humerus. But if it's loose, after a couple of days, when that deltoid relaxes, their arm can kind of sink into the sling, and then it'll look better quicker. Secondly, one of the ways to treat this is a hanging arm cast, where if you just put a cast shell over the forearm, and then you can put some kind of sling through that cast and around their neck, the weight of that cast will help pull that arm down and help align it a little better. If residents are experienced, I always tell them, hey, if you want to try a hanging arm cast and learn how to do it, go ahead. But if they're not experienced, a sling is totally acceptable as well. And then if you're going to fix it, maybe it's a 15-year-old girl and it's shifted over 2/3 of the shaft width, and you want to make it better. I always try for a closed reduction percutaneous pinning first. And the pearl on that is it's way harder than you think it is. That angle going from the shaft, getting up into the humeral head, can make you feel really silly. And then secondly, you're trying to put the pins in without damaging the axillary nerve. So you can mark an area on the lateral humerus about 5 centimeters distal to the acromion and make sure you enter there. But there's a lot of skin and muscle there. So when you enter there, you need to get onto bone before you tilt your hands down, because a lot of times you can go into the skin, but that angle is so steep that your pins will actually get to bone much higher than 5 centimeters distal. So I tell people, if you're going to do one of these, if you're a resident and you have this book, just know if it takes a while, that's not uncommon, because it's more difficult than you think.
Yeah, and is your reduction maneuver typically just some abduction of the arm, that you're just trying to get your distal fragment to meet that proximal fragment, or what?
That's right. You know, that humeral head will move all over the place. So sometimes traction on the arm and then abducting it to bring the shaft to the head can make it a little bit easier. And then it's really nice to have an assistant for this to kind of hold the arm there so that the other person can pin, because it's a little difficult to do it if you're flying solo. So if it's your first time, I would not suggest doing it alone.
Right. Of course not. Need some hands, need another pair of hands. And so to recap, again, a lot of remodeling potential from the proximal humerus. You know, if they're younger and have almost completely displaced, you can still treat these non-operatively and they'll remodel. And
that's right. So a fun little thing for, you know, any students or residents who are listening, go on Google and type in pediatric proximal humerus fracture, and you'll see examples of the remodeling potential, and you'll be amazed.
Yeah. And how is, and so that's proximal humerus fractures. And so how often are you seeing humeral shaft fractures? Because I don't think I ever saw a actual humeral shaft fracture in a pediatric patient during my rotation.
So I would say most commonly I see this in football.
Okay.
And then as you get a little older, the 15, 16, 17-year-olds, it's usually car accidents.
Right.
I would say that is what I have seen for this. And you can think of the humeral shaft as the proximal humerus light, meaning it also has a lot of remodeling potential. And so they tend to do really well non-operatively. My personal preference is to go straight to a Sarmiento in these.
Okay.
See them in like 7 to 10 days. The reason for that is I can check and make sure it hasn't, you know, displaced unacceptably. But secondly, you know, the humeral shaft bleeds a ton, so their entire arm is huge at first. And so when you put a Sarmiento on, you know, 7 to 10 days later, you're going to have to really cinch that thing up, because now some of that swelling is going away. And really, they just need it until they have enough callus to where they can move the arm without it. So typically, it's only somewhere between 3 and 6 weeks in a Sarmiento, and then they can start doing more. I do like to have the humerus completely heal before they return to sports. I don't trust that callus bone, but with callus, they can do normal activities at home and at school, just not sports yet.
Yeah, and Dr. Gibbons, you mentioned, you know, unacceptably or as far as the positioning of the humerus. What are your normal parameters that you're looking for? You see this and you're like, we can treat it non-operatively. And are there any parameters where you're like, this should probably be fixed even if they're, you know, 10, you know, anything like that?
So I would say when you're young, you know, 10 or younger, almost no reason to fix it unless it's open, or conversely, if they have like a concomitant injury on that arm. So for instance, I had a kid who was in a car accident who had a clavicle and humerus fracture. And so in that case, it's really hard to, and he had some lower extremity injuries as well. And so if he is having to use crutches, it's really hard to use that arm because of multiple fractures. And so in him, putting a couple flex nails in the humerus gives him a nice stable humerus to where he can put some weight on the crutches. When they get older, there's some parameters. It's usually about 20 degrees of angulation, 1 to 2 centimeters of shortening. When it's your non-dominant arm, you really don't notice the shortening. You can make an argument that if you're a high-level athlete, you don't want the shortening because that'll affect your muscle function if it's your dominant arm. However, if we're going to fix them, my first go-to is flexible nails.
Okay.
And the reason is small incision by the elbow. Both nails go in the same incision. You can usually get them across the fracture relatively easily. And then you avoid a big incision with a plate and screws. But I always have, ORF as a backup if I can't get flex nails in.
And are you ever worried about the radial nerve when you do that? I mean, because for this, I guess in comparison to adults, you're not necessarily reaming or anything of that sort. But are you ever worried about the radial nerve, or go and make an incision and look at it, or you typically found it's okay? Because I assume maybe because of the thick periostome with the kids. I don't know. What are your thoughts?
Yeah, so I think the rate of radial nerve palsy and humeral shaft fractures in young people is less than 5%.
Yeah.
But you bring up a good point, getting a good exam pre-op, because sometimes, depending on their age, it's hard to get a reliable exam because they see their arm looks weird. They're really scared. You're telling them to move. And so sometimes you could be tempted to be like, oh, it's okay. I'll just, we'll get an exam later. If it is in pre-op and then post-op it's out, that can be worrisome about, okay, what do I do now? So having a good pre-op exam will let you know, because if it's out pre-op, generally in this case, it's a neuropraxia, and that'll come back.
Yeah.
Typically with the nails, not a high incidence of causing a radial nerve issue, because it's all done percutaneously, as long as when you're trying to pass the nails, you're not, jamming them 5 centimeters past the fracture site out of bone.
Right.
The flex nails typically stay in there long enough until the fractures heal, usually removed somewhere around 6 months post-op. And again, small incision by the elbow. When you take them out, they're usually not super prominent. So they're kind of my go-to before considering going to a plate, unless it's a super comminuted humerus.
Okay. All right. So, I mean, main thing typically, again, in a pediatric patient, these can heal non-operatively. Sarmiento brace, occasions where you may consider fixing this are polytrauma, where they need their upper extremities to ambulate, or enable to bear some weight. And in that case, you may fix this with flexible implants. Now, moving more distal towards the elbow. And actually, I got a question on this earlier. I was doing some rest study questions, preparing for boards.
Good for you. And
I got a question on these lateral condyle fractures. One, I guess, just really quickly, a lot of us are at least starting off when we try to look and evaluate for the pediatric elbow x-ray is always super confusing, because a lot of things aren't ossified. So any just quick general tips that you have when you're looking at an elbow x-ray and you're trying to evaluate it for the pediatric patient?
Yes. So first off, one of the easiest things to look for is an elbow effusion. And the way that you see that is on the lateral. So you have an x-ray here, anterior and posterior fat pad. If you can't quite see anything, but you have a fat pad sign, something had to bleed to cause that fat pad sign. So in case anybody's listening and doesn't know what that is, you normally have fat in your elbow that sits right on bone. If something breaks and therefore bleeds, the blood gets up under that fat and lifts it up. And now it becomes something you can see on x-ray. And so fat pad sign is a really good marker for either a non-displaced supracondylar in someone young or someone older for a radial neck fracture. And so if you have any question, but you see a fat pad, you can always put them in a long arm cast and have them follow up in clinic. Secondly, the lateral x-ray tells you pretty reliably whether or not there's a supracondylar humerus fracture. So a line drawn down the front of the humerus should always bisect the capitellum. And usually, if it does not, then there's a supracondylar humerus. And since 85% of them are extension type, it's usually anterior humeral line going in front of the capitellum. Thirdly, the lateral part of the elbow in someone who is growing only has one physis, one growth center. So if you're looking at the lateral part of the elbow and you see 2 lines, one of those lines is a fracture.
Hmm.
So in this example, this one's pretty easy to see because it's off, but the junction between the capitellum and that little tiny fleck of bone that's attached to it, that's the growth center. And so the line above it is the fracture. So there's always just one line there. So if you see two, that's a lateral condyle fracture. That's kind of the basic way of looking at x-rays in a skeletally immature patient.
Okay. And so for any patients that, and just to recap for those who are listening, you just said, again, looking at for any type of a fat pad sign, looking at the anterior humeral line, which you evaluate on a lateral x-ray, and you want to make sure that that's kind of at least bisecting the capitellum. And if that's off, then you have some type of a supracondylar humerus fracture. Then also on the AP, when you're evaluating that and you're looking at the lateral side, it should be only one ossification center. So you really should only see one line. If you see two lines, something's wrong and there's a fracture.
That's right. That's the easiest way to notice a lateral condyle, because everyone is always like, is that one? I can't tell. There's only one line there. Like, look medially. There's only one line medially too, and that's the apophysis of the medial epicondyle. So a second line there is a fracture.
Those are some easy, but I like those tidbits because I remember first starting off, I was like, man, I don't know what I don't know. I'm just unless it's like blatantly obvious, I'm like, you're trying to look and see if you can see something. So thanks for those tips, Dr. Gibbons. And so when we have a patient with a lateral condyle fracture, what imaging are we getting? Typically we get our AP and our lateral. Should we be getting any other imaging? And then can you kind of walk us through how we should treat these injuries?
Yes, so the lateral condyle is a different animal because it's intra-articular. And so that makes it slow to heal. And that also means that because, like on this x-ray here, all you can see is the capitellum. You can't see the medial part of the distal humerus because it hasn't ossified yet. Right. And so you don't know if that fracture line goes all the way down into the joint. And so they have a big step off from lateral to medial of their joint. And so that's why these are a little bit different than your traditional supracondylar humerus, which doesn't affect the joint. So typically AP and lateral, but the view that you'll sometimes get tested on is getting an internal oblique of the elbow to try and see that lateral condyle a little bit better.
Okay. And so treatment options. So if this is non-displaced, how are we treating it? And if it's displaced, are there any things that will indicate you to operate on this?
Yeah, so minimally displaced, most people will say 2 to 2.5 millimeters of displacement. You can treat them in a cast. Just know that it's going to be slow to heal. Whereas in a supracondylar humerus, within 3 weeks, there's ample callus there and pins can be pulled. A lateral condyle can take 4 to 6 weeks and even longer. So if you're going to treat it non-operatively, a long arm cast, and then at the 3-week mark, take x-rays out of the cast. And the reason is it can sometimes be hard to see callus with the cast on, because if it's not healed yet, you can always put a new cast on. So that's what we're going to be doing for minimally displaced fractures. Any ones that are displaced more than 2 millimeters are going to get treated surgically one of 2 ways, and there's pros and cons of both. Sometimes percutaneously you can push that fragment over and then put a couple K-wires in it. However, if you're going to treat it percutaneously, to know what the joint looks like, you need an arthrogram. So if anybody doesn't know what an arthrogram is, inject dye into the elbow joint so you can fully see all the cartilage that's there, because it's much bigger than you think. Without that, you have no idea if you have the piece in the right position. However, for most of these that are displaced, you're going to make an incision to put it back in place. The incision is really simple. It's a lateral incision directly over the lateral condyle. Usually the fracture does all the dissection for you. So once you get into fat, all of a sudden you're going to be right down on bone. Typically, most people will put a freer or a Homan on the anterior humeral surface to kind of lift all the soft tissue up so you can actually see the joint, to make sure the joint is reduced. And then you're either treating it with K-wires or a screw. I have gone to all screws. I don't use K-wires anymore.
Okay.
The pros of a screw is you're providing compression. So you can see earlier radiographic healing. They can get the cast off sooner and start moving it sooner because you have a nice beefy screw in there. The biomechanical studies show that the screw is better than K-wires. However, the downside is possible surgery in the future to remove that screw. Whereas for K-wires, the benefit is no secondary surgery, but usually it takes a good 4 to 6 weeks before it's healed enough to pull the K-wires. So now they're starting motion at 4 to 6 weeks. In my practice, single screw up the lateral column. I do it bicortically. One, for compression purposes, but two, to prevent that screw from backing out. And at 2 weeks, x-rays out of the cast, usually you can already see healing, and let them start moving it. Typically by 6 weeks with a screw, they're healed enough to return to activity. And by that time they have full motion because they've been working on it for a month. And so that's why I prefer that. Some people will argue that it's better not to have to go back and take that screw out. And there's reasons to suggest that, but I really like the screw because you compress it down, you see it heal quick, and you can start them moving earlier.
Okay.
And you have a good picture on here about the blood supply. So the typical question that you get, whether it's OIT or boards, is where do you not dissect when you open these up? And it's posteriorly, because you can see the blood supply comes from posteriorly, and the worst thing that you can do is cause AVN in one of these kids.
Yeah, perfect. Yeah, I think you hit all the high points. You talked about the internal oblique X-ray when we're assessing these. If you are treating it percutaneously, you definitely want to get an arthrogram, like you said, and then you can open reduce and fix these with a screw, just like you're just talking about, to get some good compression. You in your practice, you said you do one lateral column screw bicortical. And then you also mentioned the point of avoiding that posterior dissection because you don't want to cause AVN to the lateral condyle. It's a bad thing to do.